Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Nick VanDuyne, Executive Director of the New York Care Information Gateway, a regional health information organization operating in the New York City and Long Island region. Welcome, Nick, and thanks for joining us.
Well, thank you for having me, David. It's a pleasure to be here.
As we all know, RHIOs have had a bumpy ride over the years, whether in terms of challenges around governance or participation or sustainable funding, and many, sadly, are no longer with us. So, Nick, can you give us a thumbnail sketch of how RHIOs work in New York State and describe the SHIN-NY and the associated funding mechanisms for those who are not familiar? To me, and I know some would say I need to get out more, to me, it's a fascinating model and worth knowing about.
Well, thank you. And it really is a fascinating model. The unique thing about New York is, we're a fairly large state, and we've regionalized the HIUs to work within their specific core areas of geography. So upstate, we're focused on the large cities of Albany, Rochester, Buffalo, Syracuse, Binghamton. And then downstate, we get a little more complex because it's so dense. So there's actually 3 regional health information organizations working in the greater New York City area. There's ourselves, the New York Care Information Gateway, HealthcareNOW, and the Bronx RHIO. It's really created a nice organizational structure where we have to collaborate and move data back and forth across all of them. And that's facilitated by the SHIN-NY, which is the State Health Information Network of New York. It's really the core piece that allows all the RHIOs to speak to each other. We have the ability to transact data from one RHIO to another, and we have the ability to move clinical event notifications throughout the entire state, regardless of where a patient shows up. And that's, again, facilitated by the SHIN-NY and the fact that we have a master patient index at the state level that we all contribute our patient identifiers to.
And so what level of detail is there in this information that may be sent across from region to region or provider to provider? And how does that compare, if it does, with what is being done, say, by Commonwealth?
That's a good question. So within the state of New York, we can send a CCDA from one facility to another. You can request information from the RHIO that you're connected to. That RHIO will go out and query all the other RHIOs and bring back not only information from a single facility, but all the information that we have throughout the state of New York into a consolidated CCDA back to the facilitated facility or the provider that requested the information. It's similar to Commonwealth in that respect, in that you can get information from a particular RHIO through Commonwealth, but in the way we're structured, any information within the state comes back. Where we vary from Commonwealth is also the fact that if you're interested in a patient and you want their clinical events, you want to know that your patient showed up in an emergency department somewhere throughout the state, we have the ability to send that to you. You subscribe, we monitor all the ADTs across the state, and if a patient shows up, then they're in a hospital and it's a patient you're subscribed to. And of course, in the state of New York, you have consent. We can send you some detailed information. And therefore, that's quite different than something that happens in Commonwealth. So in terms of managing your patients and understanding where their episodes or care are happening in a more real-time environment, that's a little something different that we do that Commonwealth and Care Quality cannot do at this time.
Okay. And among other things, that's the kind of thing that takes money. So how is this funded?
Well, the wonderful thing about the state of New York and the belief of the Assembly and the Department of Health is they've funded this through HICRA funding and other funds. And, we do this at this point in time without charging or putting any additional burden on the providers and the hospitals financially to do this. They're obviously still responsible to pay for their end of the connection. But once that's done, all the operational perspective of it is funded through the state. And, we ask for no funds from our clients at this point in time.
And is that expected to sunset at some point in the future and transition to a different kind of funding approach? Or is that too far off in the future to prognosticate?
Well, it's at this point in time, it's up through March 31st of 2021. That's what the existing funding would then run out. We are looking at ways for sustainability. How do we utilize the data? How do we partner better with our PPSs to show that there's value? Other areas in data augmentation for reporting, and working with our clients to help them determine ways that they can utilize the information, decrease their costs, and then therefore see a value in the system and be inclined to fund it.
Right. Well, also on the horizon are new interoperability rules that were released as draft not long ago and are expected to come into effect over the next year. How do you see those mandates interacting with the work that you're doing?
I think they're actually, in my mind, they're actually really good. I think they help us. I think New York is really a little bit ahead of everyone in terms of how we're interoperating. I think from a perspective of a national network in terms of getting everyone motivated to be connected and be able to exchange data, that's a great thing. I think there's some miscommunication in terms of care quality and e-health exchange and care everywhere in terms of all the use cases. They do fulfill a particular use case in that one-to-one exchange, and that's important. But I don't see that as really facilitating all the other use cases and things that we handle for our clients here in New York.
So let's talk a little bit more concretely about some of those use cases. What are some concrete situations where you see the SHIN-NY and the RHIOs adding a layer of value into the equation when we talk about the triple aim or the quadruple aim? Where are we adding value here?
Well, I think we add value in a lot of different places. Part of it, whether you want to call it analytics, you want to call it data augmentation, you want to call it reporting. It's interesting because one of the things that we do in the state of New York that we feel really strongly provides value is we're able to help in that care coordination in terms of patient monitoring to ensure that patients are actually scored correctly. Recently, we just ran a program with one of our PPS partners. We were given 19,000 patients that they needed to track their hemoglobin A1C scores on to make sure that the patients were well cared for and that the patients were actually were stratified properly. And what they found was that roughly 60% of the providers who were caring for their patients were not connected into the data set that they had. So therefore, they had a very suspect look at their individuals. So they came to us and said, help us find this data. So we went through the information that we had within our system. We went through the information that was available through the state. And we actually raised their hemoglobin A1C scores to where they were above the DSRIP requirement. And it really showed there was a nice continuity of care. And, the first thing people say is, oh, you help them get a value-based payment. That's great. And that's true. We really did. But what we really did was we took 8,500 patients that didn't need a care coordinator to follow up with them. We took 8,500 patients that didn't need to make another trip somewhere to get a blood draw. We took 8,500 patients that didn't have to have that blood draw processed. And we had 8,500 patients that therefore did not get inconvenienced to go out and have this work done. And then that also then gave the care coordinators all that time that they would have used tracking these 8,500 patients to focus on patients that they really could focus on. And we believe that saved a lot of money. We believe that both the quality of life and the quality of care for the patients who weren't inconvenienced and the patients that the care coordinators could focus on was improved. And it doesn't sound like a lot, but to us, we think it's a really important aspect of what we do.
Sure. And that's an example with a relatively small sample of patients, correct? It
is. And we did it so well. I shouldn't say we did it so well for them, but they were so pleased with the work we did that they've actually expanded the request. And we're now looking at roughly 40 discrete data elements that we're trying to help them close their gaps on so that they can care for their patients better.
So diabetes is one of those examples that keeps coming up at the top of the heap when we talk about potential uses for digital health tools and improving healthcare management and health outcomes. Are there other conditions or disease states that you see as ripe for improvement using these sorts of tools? And What about the diseases or disease states that are maybe harder to capture, that are not so data intensive in a clear numeric way?
Well, I think there's a lot of other areas that are useful for this. I think the focus areas we talk about, like COPD, CHF, pediatric asthma, these are all areas where we have the ability to help facilitate better care coordination. And then I think some of the other areas that are really interesting that we sort of forget about are things like tuberculosis. How are we doing there in terms of, are we tracking people correctly? Large urban areas that have larger immigrant populations. You have people who are, have tuberculosis. You have people who have latent tuberculosis, so it may be sitting dormant. How do we track all these individuals and care for them? And I think there's a lot of ability to leverage the RHIOs, the SHIN-NY network in the state of New York to help also do that. I mean, there's also a lot of abilities with anything that has a discrete element, right? So if you're really looking for transients, we see a lot of potential in behavioral health with homelessness. In the New York City area, there's roughly 65 to 70,000 people in a homeless shelter at any given time. There's roughly another 10,000 on the streets. A lot of those having behavioral health issues and individuals that are tough to track from place to place. And if you're a caregiver and you're working with some of these people who are housing vulnerable and they show up in a hospital, it'd be really nice to be able to have your care coordinators know that immediately and begin to coordinate follow-up care with them.
Absolutely. If you're just tuning in, this is Harlow on Healthcare, coming to you on HealthcareNOW Radio. I'm David Harlow, and my guest today is Nick VanDuyne, Executive Director of the New York Care Information Gateway. Nick, in federal fiscal year 2018, we saw a slight relaxation of the ban on the use of federal funds to develop a universal personal identification number. I'd like to talk about the issue that this touches on. Why do we need a UPIN, or do we need a UPIN? How have you been dealing with the lack of a UPIN? Because frankly, it seems to me like it's a necessary thing to have if we want to be able to coordinate records and coordinate care across multiple care settings. You've been talking about situations where people are in and out of multiple care settings, and from a logistical perspective, it's sort of hard to track who's where and whose records belong to whom if we don't have such a tool, a universal identifier. But yet we don't have that. So first, do you have any sense of where things are headed at a government level? Are we getting closer to the possibility of having that? And I know you're working on what I might call a workaround to that problem as well.
Well, I'll tell you my personal opinion first. I think the universal patient identifier is a good thing. I think patient advocacy groups, patient privacy groups are suspect or wary of it, and I can appreciate that. I think the most interesting piece about that today, in today's connected world and all the data that is freely available on an individual, becomes quite unique in that we could almost get away without having one, but it just requires a lot more research on people. Whereas if we had a UPIN, it would be much easier to make all this happen. For example, I don't know you. We've met today. If for some reason I wanted to say, I need to coordinate David's records across 2 hospitals. Maybe the addresses are different. I could reach out. There's programs with a lot of the what they call wallet-based knowledge, Experian, utility bills. I mean, people move all the time, but their cell phone number doesn't change, right? So you track. David used to live at address A. He now lives at address B. His cell phone number hasn't changed. We then begin to build a level of confidence that this is the same David. There's so many things that outside of the healthcare continuum could be leveraged to do that. It creates extra work. It creates extra cost. I think if you look at the benefits of a UPIN, I think it makes a lot of sense. And I do appreciate the patient privacy and patient advocacy groups that feel it's a infringement on the individual. I just, personally think it's a good thing, and it just would really, really help with care coordination, particularly for people who are in lower income brackets. They move more. Rent goes up $20 a month. For you and I, maybe that's not a big deal. For somebody in a lower income bracket, that means they're moving, and then you're going to see their care coordination just get all kind of askew. I just think it's a thing we really have to look at and look at the benefits of it, and have a conversation about the pros and cons. And as I said, I appreciate the privacy concerns, but I think it's a good thing.
So you mentioned the privacy concern, so I have to go there now, which is the concern about the access that the RHIO and the SHIN-NY have to all of this amalgamated information on patients across care settings. Does that make you, it does make you a target for potential hacking? And how do you address that from a security perspective?
Well, it does. I mean, everyone is a target for hacking, right? We have a wealth of data, and the general rule of thumb is that a robust patient record is worth more than my name and my credit card number on the black market. But the state of New York has been very diligent. We're all required to be high trust certified to work within their network. We also have to maintain and achieve and maintain qualified entity status, which requires the state of New York does an audit on us each year. I don't want to say we're 100% secure, because just like everyone else, you're only as secure as the threats you know about. And I think that anyone who would be flippant to think that they're unhackable is probably foolish. But we maintain our due diligence and do the best we can. We make sure that we restrict access as much as humanly possible. We have all the safeguards in place that we're aware of, and we're constantly staying abreast of all security updates and new threats as they come about, as well as maintaining our certifications for security that the state requires.
So back to our regular programming. We're talking about the UPIN and the idea of the UPIN. We're not there yet by any means. And so as a workaround to that problem, I know you've implemented a relatively new system for patient matching. I'd like to ask you to talk a little bit about that and what that's done for your organization.
Sure. So every organization that's trying to coordinate and aggregate records on patients across vast and different data sets requires some way to match them, right? So it's a master patient index. In the state of New York, every RHIO has one, and then they also point up to the state master patient index, where we do matching at that level. We used a system for quite a while, and we were kind of struggling with it. It performed well, but we felt we were missing a little bit in terms of performance. We recently switched over to the InterSystems Health Share Patient Index, which is their master patient index solution. We did a conversion and realized upon the conversion from the old system to the new system that we had about 500,000 less unique records, which concerned us. We immediately thought we did something absolutely wrong. And, you start wondering, man, what could we have possibly done wrong to lose 500,000, records in the index? But upon research, what we found is that we actually matched better. It picked up a lot of the anomalies that would have required manual reconciliation and literally matched 500,000 patients for us that we would have had to match by hand.
And this is 500,000 out of what total?
So right now we have about 11.5, nearly 12 million records in our system. And we are now, those records break down to just over 7 million patients. So that 500,000 would have been added to the top number. It would have been about 12,500,000, and also to the bottom number. So we found basically another 500,000 patients that would link to other records.
Got it. So that's a tremendous benefit.
It makes the record for the patient now more available, right? So instead of looking and saying, well, maybe this isn't the same patient, we know it's the same patient. And so they're getting more of the medical history. And we were very pleased with the outcome. I mean, again, concerned at first when we saw it, but after doing our investigation as to what happened, we were very pleased with the outcome. It was a very good outcome for us.
So that reduces the need for manual second layer work on patient matching, and it increases the accuracy of the match. And so again, you talked earlier about some of the ways in which this helps actual patient care. Are there other particular examples of the ways in which this better matching assists in terms of the ultimate work that your members are trying to do?
It does. We do a lot of work with clinical event notifications, and one of the most difficult things we have in New York, in the 5 boroughs and out on Long Island, is the opportunity for a patient to go somewhere, right? So because of the density of hospitals and the density of health systems, a patient could easily, traverse 3, 4, 5 different health systems, providers within a very small geographic area close to their home.
Sure.
And this additional matching, this better matching, allows us to actually track that better. And in terms of comorbid patients and patients with, complex disease states where the primary care provider or the provider who's responsible for their care management program, it really helps us to ensure that, if there is a typo, and which is typically where most of the anomalies come if the addresses are fairly correct, the registrar makes a typo, and then this tighter matching algorithms allow us to actually see that and then provide clinical event notifications to the individuals who are looking to do the care coordination. So we ran a program with one of our clients, and they were looking to do clinical event notification. They needed to do better follow-up on the patients that were under their care after discharge. We started with a pilot for them, and when we ran this pilot, originally at first it was a little overwhelming. We had to work with them to ensure that we weren't giving them too many alerts, and so we've worked on which alerts they wanted. They were very interested in the admits, but said, we really don't need the admit. We just need to know when they're discharged. So we'll get enough information. So we worked with the organization, and we did some work, filtered out what they wanted, sent them discharge alerts. So every time a patient that was on their list of patients that they were monitoring got discharged from any hospital within the New York area, we were able to provide them a notification that the patient was discharged. What we saw in the process was that they had a 158% increase from the same quarter prior year on scheduled follow-up, which is really important because when you look at patients, the likelihood of being readmitted within 30 days goes down drastically if a follow-up is coordinated within 3 to 5 business days upon discharge, so that the primary care provider can then give the subsequent treatment that's required. It was really, really successful for them in terms of their readmission avoidance. What they saw, and now granted this was a pilot program, but what they saw in the same quarter prior year was an increase in their readmission avoidance payment of 362%. They were so enthralled that we've actually expanded the groups that we're working with them, and we're doing a lot more clinical event notifications on a larger cohort of patients for that particular organization now, taking in more comorbid sets and more disease states that they're interested in tracking. And this is all because of the information that's available within our HealthShare platform and across the state of New York. And, also because we have the ability with our system to provide live patient updates to the state. We immediately, when we get new information on a patient, we're able to immediately match it to what's in the state. And therefore, if that patient shows up somewhere else within the next day, we would know immediately because we're matched, and that patient would we be able to get an alert on him if someone was subscribing. So for us, it's really, really important work. As a sort of a just data mover and data augmenter in the middle of things, a lot of people think that what we do is somewhat unglamorous and really not a key part of healthcare. But we like to feel that, we're really putting the right information in the right place in timely manners so that people can actually do the work they need to do.
So, Nick, to wrap things up, if you were to wake up tomorrow and find yourself 5 years in the future, what's one thing in healthcare that you would hope or expect to find has changed dramatically?
Well, I think that personalized medicine through the concepts of understanding an individual's DNA and how their DNA works with, being prone to certain illnesses, I think that that's really where we're going to go. They talk about the person who's going to live to be 150 who's already alive today. I don't doubt it. I really think that the science has just gotten so amazing. And I know it really has nothing to do with what we do here at New York Care Information Gateway, but I really think it's that personalized medicine based on DNA structures that's really going to take off in the next 5 years and is really going to do amazing things for us as humans and as a benefit to the entire world.
Well, if someone lives to 150 and ends up moving to Mars, they'll need to get their medical records and we'll know who to call.
That's true.
Great. Thanks for taking the time. I appreciate it.
Thank you, David. Thanks for having us on and appreciate the opportunity. Thank you.
You have been listening to Harlow on Healthcare. Join us at HealthcareNOWradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.